Okay. I'll talk loud so you can all hear me. All right. So this was, after the last talk, we're going to talk, just sort of go through the strips. So at first it's going to be just sort of the things you usually see. And then there are some modes on the device that will cause things to appear on the monitor that if you have seen it before, it won't look strange. And if you haven't seen it, you'll say, why is it doing that? That's weird. Okay. So first we'll talk about single and then the dual chamber. And this is sort of the sort of mental way to go through it. So you guys should pay attention to this slide because I'm going to ask you to do this on all the ones that we're about to look at. So gather information, obviously. So measuring the intervals, it's much easier to measure it in milliseconds. You know, you were probably taught to count, 300, 150, 75, 300, 150, 100, 75, 60. But last time I had mentioned that the magic number is 60,000. So if you just count the number of boxes in milliseconds, remember each big box is 200 milliseconds and each small box is 40. So you go from R to R, you can get the number of milliseconds. 60,000 divided by that is your heart rate. If you have a heart rate, 60,000 divided by your heart rate is milliseconds. So it's the same math every time. So then you convert the rate. But the main thing you want to do is, in your head, think about looking at the capture separately, look at the sensing separately, and look at the underlying rhythm separately. If you try to just look at it and do it as a pattern recognition, you can get tricked by the changes that you see. So in your head, it's capture first, then sensing, then the underlying. And we'll do that so many times that you'll get sick of it. So this is, remember, I'm telling you in advance, this is a single chamber pacemaker. So I'll do the first one or two and then you guys will do them all. So for the sensing, for the capture, every time there's a pacer spike, there's a ventricular complex. The ventricular complex is wide, it looks paced. So it looks like there's good capture here. The sensing is unknown because there are no R waves to see if the device recognized it or not. And it's perfectly fine if somebody's paced all the time to say sensing is unknown. And the underlying rhythm here, you would say, is complete heart block because the P waves are unassociated with the complexes. And that's fine here because it's just ventricular pacing, single chamber. So VVI pacing, I didn't do the count, but you could count big boxes and small boxes and divide by 60, you get the rate. There's appropriate capture. Sensing cannot be determined. Okay? Why is it not going to the next one? Oh, there we go. EKG number 2. So this one has a couple of other things in it. First, you look at capture, and this first one looks like what you expect. It's got a pacing spike, and it's a wide QRS. And then this one looks different than this one. What's the problem? This makes you remember what we talked about 2 weeks ago. See, some pace beats look like this one. Mm-hmm. This one looks different. This one looks even more different. There's a pacing spike next to that complex. This one looks different, probably looks the same as this one. And this one looks the same as this one. So what's going on there?
There's like a beat when it's trying to pace at the same time.
What's that called?
I forget the word.
Fusion.
Fusion.
So this beat and this beat are fusion beats. The pacing spike is part of how it's depolarized, but it's a mixture. Some of the signals coming down the conducting system, so that would make it narrow, and some's coming through the muscle itself, and that makes it wide. So the hallmark of a fusion beat is it's narrower than the completely paced beat, but it looks very different than the native beat. And then what's this one called? This is the other word that we used.
Is that the pseudo?
Pseudo fusion, exactly. So this beat looks exactly the same as a normal beat. So this one looks exactly the same as the normal beat, except that it has a pacing spike in it. So that pacing spike is not actually affecting the beat at all. So that's pseudofusion. So going through the same little list of things, capture first, then sensing, then underlying. What do you think about the capture here?
It's captured.
Yeah, it looks good. Every time that there's a pacing spike, it's either captured or in this case, not captured because the heart's already beating. What about sensing?
Yes.
Yeah, every time that there's an intrinsic beat, the pacemaker is suppressed, it's inhibited, and then the interval from there to the next pace beat is the normal pacing interval. So sensing looks like it's working as well. And the underlying rhythm, it's single chamber. So this beat, and this beat look like they have one-to-one association with P waves. But, you know, the sinus node function is not normal. That's why this pacing is present out here. No P waves. So it's BVI pacing. Beats 3 and 6 are fusion. That's this one and this one. Beat 4 is pseudofusion. And there's appropriate capture and sensing. Who wants to do this one? Oh, volunteers. All right, so what's this beat?
Pseudofusion.
What's this beat?
Pacing.
Paced. And what's this beat?
Fusion.
Exactly. So this one looks the same as the normal beat, except it's got a spike on it. This one looks like a combination between the wide QRS and the narrow QRS, so it's the true fusion. All right, capture,
Yes.
sensing,
Yes. Yeah.
okay. How about here?
Pacing.
There were 5 pace beats.
So pacing first, actually capture first. These, every time there's a spike, is there an appropriate complex?
Yes.
What about sensing?
Yes.
You sure?
There is a little pause after the
Pause
3
out here.
intrinsic beats.
That's right. So this would be something that we didn't talk about last time, called hysteresis. And you probably heard the term on the floor. Hysteresis means that we can set a rate that is lower than the pacing rate to start pacing. So, for instance, if the pacemaker is set at 60 beats per minute, and we set hysteresis at 50 beats per minute, then that means that it'll pace it's no slower than 60 whenever pacing is needed. However, if the patient's own rhythm is there, it'll wait until the rate gets below 50 to start pacing. And when it starts pacing, it'll be right away at 60, because 60 is the lowest rate that it's set for. And what that does is it keeps the pacemaker and the patient from competing with each other. If the patient's own rate is extremely close, if not the same as the pace rate, then they could compete with each other. This way, the rate has to get down to 50, and then it starts pacing at 60. But that only happens when it's going from the patient's own rhythm to a paced rhythm. So this is the patient's own rhythm. There's a longer RR interval here. That's the hysteresis. And then if we had more beats down here, it would look like these. It would be at the pacing rate. So if it looks like there's a long RR interval at the onset of pacing, that's hysteresis. The other issue with hysteresis is there is a gap in there. You know, if hysteresis is set to 50 and the patient is at 60, the patient might be on their own at 55. Hasn't reached the 50 that's necessary to trigger pacing, but it's still lower than the base rate, which is 60, and that can often be confusing. Patients set for 60, how come they're not pacing now? Their heart rate's down to 55 or 53, and that's because of hysteresis. Or it's most likely due to hysteresis.
Is that like a setting that you guys?
Yep.
Okay.
Yep. And we can set it at 5 beats below or 10 beats below. That's the typical thing. So this is BDI at 60, appropriate capture and sensing, and this hysteresis at 50 per minute down here. Okay, who wants to do this one?
I'll go for it. I'll take one for the team.
Go ahead.
I would say it is capturing.
Capture is good.
So, on the third beat there, would that be considered a pause, or is that still sensing because there's a pacer spike right after it?
What is this beat?
It kind of looks like PAC, but I'm not really.
Is this beat and this beat look the same?
No,
What's this beat?
that is being paced.
That is being paced. It
Yeah.
has a pacing spike on it.
Yeah.
What is this beat?
Is it a PAC?
Close.
PVC.
PVC, right. So this is a QRS complex, so it's ventricular, atrial, or P waves. So it's wide, which means it's not coming down through the normal conducting system, which these are. So this is a PVC.
Mm-hmm.
Does the pacemaker think a PVC is normal or abnormal? It thinks it's a normal beat. The pacemaker just senses whether something got detected.
Yeah.
And if it did, then it says the patient's heart
Okay.
had a beat. So the pacemaker doesn't know the difference between sinus beats and PVCs. It actually does, and we'll get to that later, but for the purposes here, it doesn't. So patient's beat, PVC,
Yep.
and then a long time before pacing starts, and the pacing rate is higher than this rate. So what's that?
Is that going to be an example of the hysteresis right
That's
there?
exactly right. So the pacemaker doesn't know that the PVC is different than normal beats, but the hysteresis rule still counts. If it's transitioning from the patient's own rhythm to a paced rhythm, then the hysteresis time is what counts. Then it's normal beats,
Yep.
then a PVC.
And then another one.
Pacemaker says PVC, that's the patient's own rhythm. So in order to start pacing again, I have to wait till it falls below the hysteresis rate.
Mm-hmm.
So normal sensing, PVC, normally sensed, hysteresis rate, pace at the pacing rate. PVC, pacemaker thinks that's coming from the patient, so it waits the hysteresis time before it starts to pace again. Okay. Your turn.
Okay. Thank you. So we have, starting at the beginning, a pseudo fusion beat,
Nice.
and then an intrinsic beat,
Yes.
followed by a series of paced beats, 1, 2, 3, 4, 5, and then those next two look like fusion beats.
Yep.
And then the last two, I'd say there's no capture with those
Okay.
two.
So we're gonna go through the usual things: capture, sensing, and underlying rhythm.
Okay.
What do you think about capture here?
I'd say capture until the last two beats.
What do you think's happening on the last two beats?
And the spike is after the QRS.
Right. So what happens right after a QRS? The heart is refractory.
Okay, yeah.
So this is what we call, it's a term that we haven't used yet, functional non-capture or functional failure to capture. In other words, it's what's supposed to happen. It's
Okay.
normal function. So if there's a pacing spike during the time that the heart is refractory,
It doesn't
then the heart's
pace.
refractory.
Right.
It's not going to beat.
Okay.
So if the pacing spikes are at a time where the heart's not refractory and there's no QRS, that would be a failure to capture.
Okay.
This is called functional failure to capture
Okay.
because it's not supposed to happen.
Right. Makes sense.
So let's go through the things. So pacing, what would you say about pacing?
What?
I mean capture.
Capture.
Yeah.
So capturing, for the first part, and then it's non-functional. So it's still capturing.
Normal capture with some
So
with some fusion,
fusion and pseudo.
and some functional non-capture.
Okay.
What about sensing?
Yes, sensing.
So look at this. What do you think about that interval there compared to the pacing rate?
It's shorter.
Why would that happen?
Is it the patient's normal rhythm?
Well, this is the patient's normal rhythm over here. But why is this pacing so close to the last complex? Because it didn't see it.
Oh. Okay.
That's a failure to sense.
Okay.
Okay? Why are these spikes happening after the QRS?
Because it's not sensing.
Because it's
the
not
QRS.
sensing. So the problem here is not a failure to capture down here. That's functional non-capture. But it shouldn't be, the spike shouldn't be there because normally it should sense.
Intrinsic.
So this is normal capture with some functional non-capture and a failure to sense.
Makes sense.
Okay? All right. Who wants the easy one? You want the easy one?
Looks like in the beginning some pseudo fusion.
Well, what's this be?
Paste.
This beat? This one looks a little narrower than this one.
That would be the pseudo fusion.
That's pseudo fusion. What about this
Same.
one? And what about this
Same.
one? Well, this one gets wide again, so this is probably paste, pseudo, pseudo, paste. Excuse me. Sorry, I'm wrong. Paste, fusion, fusion, paste. It's not
Okay.
pseudo fusion. These
Oh,
are
sorry.
wide, they're abnormal,
Okay.
but they're not as wide as a fully paced beat. So that's fusion. Fusion meaning a mixture of the two. These are the pseudo fusions out here, because the spikes don't alter the normal shape and size of the QRS. So, paste, fully paste, fusion, fusion, fully paste, pseudo fusion, pseudo fusion, pseudo fusion, and normal. Going through the little checklist in the head, what do you think about capture?
Appropriate. Yeah.
What do you think about sensing?
It's sensing.
Excellent. So normal capture and sensing, some pseudo fusion and some fusion. Okay. This one. Your turn.
Oh, God. So B1.
You weren't here at the very beginning.
I
So
wasn't.
in your head, what you want to do is first look at whether,
The
at
pacing
the
spikes.
capture,
Okay.
then look at sensing, and then look at the underlying rhythm. Do them in those 3 steps, rather than trying to put the whole thing together all at once.
Okay.
All right. So, capture
Where's the
first.
Capture.
So is this one capturing?
Yep.
What's this beat?
Not capturing.
Well, there's no pacing,
No pacing yet.
so you don't have to worry about that yet.
Okay.
So capture only occurs when there's pacing. Is there pacing here?
No.
Well,
Well,
there
there's
is.
a pacing spike, but
There's
there's
a,
no QRS.
so the pacemaker fired,
Okay.
and there's no QRS.
So is that a fail to capture?
That is a failure to capture.
Okay.
But, and I don't know when you walked in, we talked about the difference between true failure to capture and functional failure to capture. Functional failure to capture means it's, the pacing spike is occurring when the heart's refractory.
Oh, so this would be a functional.
So this probably is functional, it's in the T wave.
Okay.
Yep. So it's not
This is
out
refractory.
here in between beats, right?
Okay.
So this is a pace beat, this is Functional non-capture. What's that one?
Another paste beat.
Capture,
Another capture.
capture. What about this one?
So that's in the refractory, so that'd be that functional.
And this one?
Same thing, functional.
And then this one?
Capture and capture.
So what do you think overall about capture here?
1, 2, 3, 4, 5 captured.
Yeah, I would say this is normal capture.
Okay.
The only ones that are failing here are functional. So that has to do with just normal physiology.
So
So
is
there's-
that okay?
Yeah, so there's no problem with capture. You can't pace a heart when it's refractory.
Right.
Yeah. So there are no problems with capture here.
So if the pace was firing in the refractory period, that isn't any harm?
Well, we're just talking about capture now. Now we're going to talk about sensing. What do you think about sensing in this case?
No sensing, right?
There's pretty much no sensing.
Okay.
So if you look from here to here to here to here to here to here, the
It's normal.
pacing interval is completely uniform throughout this whole tracing. And when the heart's not refractory, it paces. When the heart is refractory, it doesn't pace. Has nothing to do with the ability of the pacer to capture. Has to do with just the randomness of whether it's landing at a time when the heart's refractory or when the heart's not.
Okay.
So this has normal capture and failure to sense. Okay. Or this is VOO pacing. And this is where I said it was completely uniform all the way through. VOO, remember, this is the chamber paced, the chamber sensed, and the mode. And O means it's turned off. So this patient is programmed to have no sensing. Why would you ever see this on the floor? This is something,
Exactly.
fortunately, you don't see very often, but you're at risk for seeing all the time. So this is somebody usually is pretty much pacer dependent, who goes to the OR and is going to have some kind of surgery, and they're going to use cautery. And cautery generates electrical signals, and the pacemaker doesn't know that there's any other kind of electrical signal other than QRS complexes. So if somebody goes to the OR and they're dependent upon their pacemaker, and you use cautery, they won't have any pacing during that time. So we reprogram them to VOO during surgery, and then they're supposed to be set back to their previous settings when they come back to the floor. And if they forget that step, you're going to see this every time. Okay? The other situation where you get this is, what else does VOO? Somebody went into the room and checked the device with a magnet. The magnet puts the device into asynchronous pacing. So magnet or a failure to take someone out of a perioperative VOO mode. Okay, what's this?
No sensing.
No sensing. What else?
But it is capturing.
Is it? Or is it capturing?
Or no, sorry. No, not capturing, sorry.
Right, that's far enough away from the
Yeah.
previous beat that this is not functional anymore. So, no sensing, no capture.
And it's going at just the set rate.
Yeah, it happens to be very close to the patient's own rate. So,
So
what do you
the
think happened here?
So I should have a question. So as far as the pace, so there's set pacer spikes.
Mm-hmm.
So the pacemaker was programmed for that,
That's correct.
but it's not firing off the beat, right? So if those pacer spikes weren't there, would they still have that same rhythm?
Yes, because these beats are not paced,
So then I guess what's the point of the pacer?
because at other times they probably
Do not.
do need rhythm support.
So if their heart didn't beat, that pace would capture? It would-
No, it's not capturing.
Okay.
So if they didn't have their own beats here, and this is a slow, wide beat, so that's what's called the ventricular escape rhythm.
Mhm.
if you were to count this out, let's do it, 200, 400, 600, 800, 1,000, 1,200, 1,400, and 80. So who has a calculator? Cell phone. What's 60,000 divided by 1,480?
About 40 and a half.
Yep. So they have a ventricular escape rhythm in the 40s, which is where you'd expect it to be, right? Normal rhythm's right around 60. Junctional rhythm in the 40 to 50 range, and ventricular escape in 30 to 40. So it's wide, it's 40. So this is a ventricular escape rhythm. They probably need a better rhythm than that. That's why they got their pacemaker. But this pacemaker is pacing, and there are no QRSs there. So what do you think about capture?
We're not
It's a failure to capture. What do you think about sensing?
Well, it is sensing that
It is sensing.
there are
It
could
saw
be
this
beats.
beat, so it didn't generate a spike until here. And there's this nice one-to-one connection. It saw this one, it waited the programmed pacing interval, and it paced. Waited the programmed pacing interval, and it saw something, so it didn't pace.
So
Waited.
it didn't see it. It didn't see a pacer spike.
That's correct.
Got it.
All right. So this is no capture, and it looks like normal sensing. Okay. What about here? Capture, sensing, and the underlying.
So we're gonna capture in the first one.
Good capture there.
Capture in the fourth. Good.
Yep.
And then the last two.
Yep. So some beats are capturing well. What about others?
Yeah, non-functional capture.
Yeah.
No, because this is before the QRS. So the heart's not refractory before a
right,
heartbeat,
right.
only after.
After, yeah.
So we've got some failure to capture here and here. Okay. This one is a pseudo-fusion. It's
Pseudo-fusion.
hard to say, but these two clearly are before the QRS.
Mm-hmm.
So this is a failure to capture. What about sensing?
Sensing.
Yeah. These are sensed, so there are no spikes. And if you were to get your calibers out from here to here to here to here, those are nice constant intervals. It's not sensing this beat or this beat because the pacemaker is refractory, just like the heart is. Immediately after it fires, it's refractory for a short time. So it's not a failure to sense here or here. It is a failure, actually, it's not a failure to sense here and here because this is occurring in the refractory period after the ventricle fires. So there's failure to capture, or intermittent failure to capture, I guess is the best way to say it. Normal sensing. Okay. Most common reason to have intermittent non-capture is if there's, for some reason, something is pulled on the lead, usually twiddlers, things like that. And then respiratory variation, the heart is lower in the chest, further away from the can, more tension on the lead during respirations. So if you had a much, much longer strip of this, you might see that those episodes of intermittent non-capture probably vary with the same timing as the respiratory cycle. What about this one? Capture sensing.
Capture in the last three.
Yep. The capture good or bad?
Good.
What about this one?
That's a functional non.
Functional, so it's good. What about sensing?
There's a period where there is no.
It's intermittent sensing, so it saw all of these. See, there are no pacing spikes there.
How come there wouldn't be a pacemaker spike at the end and there were fractures?
At the end of which?
Like in between like after the QRS.
Oh,
So
well,
it's
it's
there.
delivering the energy into tissue that cannot be depolarized.
Okay.
That's, remember how really intimidate you there.
I know, I'm feeling it.
The potassium goes out of the cell and the sodium comes into the cell and it changes the voltage, the resting membrane potential. And that's what causes the cell to fire or depolarize, whether it's muscle or cardiac or anything like that. And then comes a period of time where all the ion pumps are restoring the potassium inside the cell and the sodium outside the cell so that it can fire again. And during that time that things are being reset, it doesn't matter how much you stimulate the cell, it can't fire. That's what refractory is.
Okay.
All right. So this is functional non-capture. This capture all looks good. So the capture side of things looks good. What about the sensing side of things? It's intermittent. It did see these, but look how short this interval is, and it's still fired.
If you didn't sense the one prior.
It didn't sense this one. If you got your calipers out and you measured from here to here, you'd find it was the same as from here to here. So it sensed this beat, but it missed this one. So it's intermittent sensing failure, but normal capture with functional uncapture over here. So functional non-capture and intermittent undersensing. When we talk about sensing failure, I should mention before we get to the rest, there's undersensing and oversensing. Undersensing meaning that, electrical activity that the pacemaker should be able to see it, it can't. And oversensing means it thinks it sees stuff that's not there. And that could be noise from the chest wall muscles, could be atrial fibrillation, could be the fact that they're working on their lawnmower and the ignition cable delivering electricity to the spark plug is being sensed. You'd be amazed when people drop their chainsaws when they have a pacemaker because it's suppressed. It's a real thing.
You should put that on your discharge paperwork. Do not handle chainsaws.
So this is, oh, I'm sorry. So what do you think about this one? Capture, sensing. What's going on with capture?
So we have non-capture on the first one. On the second one.
This one's still in the T wave. You don't know if that's functional or not.
The next
So
one.
This one
This
probably,
one.
It's outside of
yeah,
the.
this one probably should be capturing, right? You get way out here, this is coming before the QRS, so this absolutely should be capturing.
Right.
So what would you say, do you see any pace beats here at all?
No. And
So what are you gonna say about capture?
No,
No.
capture.
non-capture.
Failure to capture. What about sensing?
Not
It's not.
sensing.
There's no evidence of sensing here either.
Would that be like oversensing, or is that?
So this is, yeah, this is, well,
Not really sensing.
it's hard to say, probably undersensing, because it should be able to see these various complexes, and it's not.
Oh, okay.
So it's undersensing.
Makes sense.
So it should be able to see this one, and it's still,
Still firing.
yep, still fired. So it undersensed things. So this is a ventricular undersensing and non-capture. And to save you the pain, this one is the opposite. This is oversensing. So you see there's long gaps here with no pacing spikes. And it looks like there's no real P wave, but there's some variation in the rhythm. This is probably a fib. So that fib is being sensed
That's a beat.
down into the ventricle as electrical activity. has a name called far field sensing. It's sensing from afar, sensing atrial activity in the ventricle. In any event, it's over sensing. And when it over senses, it thinks it saw stuff that's not there. So it says to itself, self, I shouldn't have to pace right now because I sensed something. It's over sensing. Capture here is normal. So it's normal capture. And there's evidence of over sensing. So what we can do is we can change the sensitivity. We can change how many millivolts of a signal it has to see in order to count it as a complex. And if there's oversensing, we just make that larger. So instead of 1 millivolt, it may have to get to 2 millivolts. And that way that noise won't be sensed. Who wants to do this one?
Capturing.
Yeah, the capture.
Okay. Capture is good. What about sensing?
We don't have anything.
Well, you could say there's nothing there to sense, but see how here to here to
It's
here
not
is a normal
consistent.
interval?
Yeah.
And then it's long. And then here's that normal interval again, and then it's long. So what do you think's going on?
Would that be mixed up over the hysteresis there or no?
Because it's
No,
not.
because
that's not
hysteresis
before,
needs
after.
the transition from your own rhythm
Right.
to a paced rhythm.
Okay.
This is completely in a paced rhythm.
Okay.
That's the trick on this question. It's, oh, it looks like hysteresis, but it's not. So this is another example of oversensing. So from here to here, it
It
must have
thinks that
sensed
there is a-
something,
Okay.
and from here to here, it sensed something that delayed the output. So it's normal capture and ventricular oversensing, intermittent oversensing. So this is where going through that thing in your head that says capture first, then sensing, makes it more digestible. And this is still single chambers. All right, so let's go through it. What's this?
PVC.
What's this?
Paste beat.
What's this?
PVC.
What's this?
Paste beat.
What's this?
Paste beat. Intrinsic. Intrinsic. PVC. Intrinsic. PVC. Paste.
Excellent. So what do you think about capture here?
We have capture.
Every time there's a spike, there's an appropriate QRS. So capture, it's capturing. What do you think about sensing?
It's sensing appropriately as well. I mean, it's seeing the PVCs.
Is it?
as-
Look at this one.
Oh, right, I forgot the further one. So it's
Maybe under sensing, right?
That is correct.
intermittent under something.
So it's, but you see what's going on here. It is sensing. All right, because there are no
Right.
pacing spikes here, and it's not sensing here. So this is normal capture and intermittent undersensing. Okay. And I'm gonna, after this one, I'll skip over to the duals so that we don't run out of time. Okay, so. Capture looks good. What about sensing? Think this interval here and this interval here are the same?
No.
So what's going on? This is the hysteresis, because we're making the change from the patient's own rhythm to the paced rhythm. And that's why you have that longer gap in there. Okay? So, when you have variable intervals, you always have to make that distinction between, is this a sensing problem? Or is this something that should be there? And if it's a transition from normal rhythm to a pace rhythm, that's what hysteresis is.
What happens at the beginning of the skip too, right?
Yep,
As
and
well?
this one
Okay.
here.
Yeah.
All right, let me go to. All single. Are these the same?
looks like it's single up to 27. And then it goes to dual.
Okay. So it's gonna be the same kind of thing, except you're gonna go in your head through the extra steps. It's capture, then sensing at the atrial level, and then capture, then sensing at the ventricular level. Each of those 4 steps. All right. What do you think? Of course, I'm going to start with a normal one first. So in each of these, what we're going to do is put up some information about the pacemaker, because unlike a single chamber thing, you want to know a little bit about how it's programmed. So in the upper corner, it's always going to say what the base rate is. That means the rate at which it shouldn't go below, except of course it can go below because you can have hysteresis, right? MTR is maximum tracking rate. For every P wave, and there's no QRS complex, it'll provide one up to a certain rate. So the maximum tracking rate is 120. It should never pace above 120. AV delay is like the PR interval. And then the PVAR, the post-ventricular atrial refractory period. In other words, every time the ventricle fires, it shuts off sensing in the atrium so that a signal can't, because the ventricular signals are so much bigger, the atrial wire could sense that. So right after the ventricle fires, the pacemaker shuts off atrial sensing for a finite period of time. That's called the PVAR. And that'll be very important in some interleader rhythm. So in this case, this is normal AV pacing. For every atrial spike, there's a P wave. So atrial capture is normal. You can't say anything about atrial sensing because there are no P waves to sense here. This shows normal ventricular capture, and you have no, ventricular sensing is indeterminate because you don't have any R waves to sense.
Why can't you sense the atrial?
Because there are no P waves. None of the patient's own P waves there.
Gotcha. The only reason the P waves are there are for the patient's.
That's correct. So that's the normal RR interval. That's the base rate. Normal atrial capture, sensing is unknown. Normal ventricular capture and sensing is unknown. So in this one, capture, we're just looking at the atrium now. Capture, 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 capture. So atrial capture looks good. What about ventricular capture? Capture, capture, capture. Any problems down here? No, the QRS is there.
Intrinsic.
So every time there's a ventricular spike, not the atrial, but the ventricular spike, it captures. So atrial capture is good. Atrial sensing is unknown. Ventricular capture is good. And what about ventricular sensing?
It's good.
It's good.
Because it noticed.
Here it's appropriately pacing the ventricle. Here it's not pacing the ventricle because it sees one. From the atrial event to the QRS should be no longer than 200 milliseconds because that's what the device is programmed for. Now it gets a little tricky. Of course it gets a little tricky. When there's pacing, we measure the PR interval or the AV delay from the pacing spike to the beginning of the QRS. When it's sensing, because of the way the electronics and so forth work, the signal has to be there first. It actually senses more towards the end of the P wave. All right? Because the sinus node is up here, the pacing wire is stuck into the side of the atrium here, and that electrical signal has to travel through the wall of the atrium to get there. So by the time the pacemaker sees that signal, there's already been some atrial depolarization. So the PR interval, if you can rephrase it, The AV delay is from the atrium to the ventricle. Remember, A and V has to do with pacing activity. Intrinsic activity is always called P and R, just like always. So the PR interval may be programmed much shorter than the AV delay. In practice, they're the same as far as the heart's concerned. But electronically, it takes longer for it to go from an atrial spike to the ventricle than it does if it's the patient's own. So normal atrial capture, atrial sensing is unknown because there are no intrinsic P waves. Normal ventricular capture and normal ventricular sensing. What about here? Atrial sensing. You think atrial capture? What do you think?
Yes.
No, the sensing part, the sensing.
Well, we haven't gotten to sensing yet. Atrial capture, atrial sensing, ventricular capture, ventricular sensing. So, atrial capture, what do you think? Good or not good?
Not good.
Not good. Here's an atrial spike and there's no
No
P
P
wave.
wave,
Here's an
yeah.
atrial spike, there's no P wave. What about atrial sensing?
Yes.
Yeah.
It's good. Every time there's a P wave, it seems to be sensed because there's no. What about ventricular capture?
Yes.
Looks good. What about ventricular sensing? Unknown. Okay?
Those P waves in the front, those are the patient's own P waves.
That's correct.
Okay.
Yep. Because you see, the ones that the pacemaker provides have a big.
Okay.
All right. So this one's a little bit different. The base rate is 60. The maximum tracking rate is 120. The AV delay is 200. That means to go from an atrial spike to a ventricular spike is 200 milliseconds, which is one big box, and look at that, it lines up exactly. The PV delay from the patient's own P wave to a QRS is shorter because, remember, it's sensing the P wave after it's already been traveling through the heart for a little while. So we try to estimate the difference. So the actual time between an atrial contraction when it's paced, getting to the ventricle, and an atrial contraction when it's the patient's own rhythm, getting to the ventricle, are the same. That way it's physiologically the same. So the AV delay is 200, the PV delay is 150. And we say the minimum PV is 75 milliseconds, and the PVARP, which we'll get to later, is 250. So, atrial sensing. What do you think?
Yeah.
Yeah, it sees these very well, and it provides those. What about atrial capture?
Yes.
Ventricular capture?
Yes.
Ventricular sensing?
Unknown.
Unknown. And you see here, the AV
Interval.
interval is wide, but the PV interval is much shorter.
I have a question for the fourth beat, there's one pacing spike. How do you know if that's a ventricular capture or a atrial sense? Is there a way to tell?
Well, a spike is always about capture. Sensing never involves spikes. Sensing is the pacemaker's ability to see things,
Okay.
not to do anything.
Okay.
Spikes are always about stimulating either the atrium or the ventricle.
Okay.
So normal atrial capture, normal atrial sensing, normal ventricular capture, and ventricular sensing is unknown. Okay. Atrial capture.
Yes.
Yes.
Atrial sensing.
Not a different one.
What was that? Atrial sensing?
Unknown.
Unknown. I agree. Ventricular capture.
Yes. Right before the fourth.
We don't have any.
No, that's a failure to capture, right? The QRS should start at the spike,
Oh,
okay? So this is normal atrial sensing and capture. Ventricular failure to capture here. How about anywhere else? There are no other ventricular spikes. And what about ventricular sensing? That's fine, that's why there are no other ventricular spikes. So this is normal atrial capture, normal atrial sensing. Failed ventricular capture, but normal ventricular sensing. Yeah, they're talking about atrial pseudofusion. I'm not going to get into that. The loss of ventricular capture. And functional loss of ventricular sensing is,
How can you determine that if you don't have?
well, this beat is occurring so close to the ventricular spike that normally you'd expect the normal aura pacing interval to start here, which would be somewhere out here. But it didn't sense this. And the rest of the time there's normal ventricular sensing. So this is functional failure to sense on the ventricle because it's immediately after the ventricular pacing spike. Okay, atrial capture. That's correct. Atrial sensing.
Except for the
Third.
third, yeah.
Well, this is kind of a fusion,
Okay.
all right? So
Atrial
remember, the
fibrillation.
sinus node is up here and the pacing lead is down here and it's got to travel. So this has already fired. It hasn't arrived here yet by the time the little clock says
So
the
it
pacing
fires
spike,
anyway.
so it fires.
Okay.
So that's atrial fusion. So normal sensing, what to do? Atrial, normal capture. Every time there's an atrial spike, there's a P wave. What about atrial sensing?
Yeah,
Normal sensing.
normal, yeah.
What's
There's a
that?
P wave in it.
It
Senses
saw
it.
this one just fine.
Yep.
Ventricular capture
Yes.
and ventricular sensing.
Yes,
Yes.
'cause it's on
Yep.
the two.
Atrial fusion, yeah. Normal atrial sensing, normal ventricular capture and sensing. All right. Atrial sensing?
Yes.
Excuse me,
No, no.
I'm back now.
capture.
Atrial capture?
Yes.
Yes.
Yeah, atrial capture, normal atrial sensing,
Unknown.
unknown. Ventricular capture
Yes.
and ventricular sensing.
Yes.
Yes.
Okay, and this is
Is it
fusion?
fusion?
This is normal, actually, this is probably normal, this one may be a little narrower, this may be fusion, this is fusion as well, because it's not the same as the normal QRS, which is what you need for pseudo fusion. Okay, atrial capture,
Yes.
atrial sensing,
Yes.
ventricular capture,
Yes.
and ventricular sensing.
Yes.
Yep. So this, from a distance, looks like a lot of stuff going on, but it's just completely normal stuff. All right, atrial capture.
Yes.
What's going on here?
That one does not.
So there's,
That was
So
only sense, right?
No, but just talking about atrial capture, is there a problem here? That you have a spike and you don't have a P wave?
So is that a failure?
Is that a functional failure? 'Cause there's
Excellent, that's
P wave.
atrial functional failure to capture. It's right after the preceding P wave, which wasn't seen, that's a sensing problem. But as far as capture goes, the atrium's refractory here, so that's a functional failure to capture. So normal atrial sensing with functional beat. What about, normal atrial capture with a functional beat? What about atrial sensing?
We don't know.
Well, there's a POA.
Intermittent failure to sense. Actually, we can't even say it's intermittent. We can just say it's a failure to sense because all of these are paced, and it didn't see this one, so it's failure to sense, or under sensing. Ventricular capture.
Yes.
Ventricular sensing.
Unknown.
Exactly. Okay. Atrial capture.
Yes.
Atrial sensing.
Yes.
Ventricular capture.
Yes.
And ventricular sensing.
Yes.
That looks pretty normal to me. Okay.
It really doesn't. Yeah, yeah.
Is it more digestible to go through it
Yes.
in this,
Yes.
Yeah, much better.
this step?
Yeah.
Okay. Atrial capture?
Yes.
I agree. Atrial sensing?
Yes. Is that
Ventricular
third
capture?
one?
Yes.
What about this guy?
Or the third one.
Well, or this one? What's
Is
going
that the
on?
refractory? Oh, that's
The functional.
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 It's right after the QRS, the ventricle is refractory.
Mhm.
So that's not a failure to capture. And ventricular sensing?
I didn't
hard to
sense
tell.
those.
Right, so this is an intermittent failure to sense because actually you don't know if it's intermittent because all the other ones are
Yeah.
paced. You don't actually see any normal sensing. So you'd have to say normal ventricular capture with some functional stuff, but no ventricular sensing. Okay. Atrial capture? Atrial sensing?
Yes.
Ventricular capture?
That 4.
Yes or some?
Yes, but there's that 1, 1, 2, 3, the fourth one.
What about the fourth one?
It's a fusion beat.
Is it
Fusion
suit-
beat?
Oh,
So
no, it's
that's
not
still
suit.
normal?
Mhm.
And ventricular sensing?
Yes.
Yes.
Yep. There's a 20 fusion beat. I'll stop prompting. What do you think? Atrial capture. Whoa. Oh. Okay.
Atrial capture.
Normal capture.
All right.
Normal.
Atrial sensing?
Sensing.
Normal.
What's that?
Normal.
Normal. And ventricular capture?
Yes.
And ventricular sensing?
Yes. There's that one.
Yes.
Yep, just one beat to see, but it's up there.
Normal atrial capture.
Yes.
Normal atrial sensing. Normal ventricular capture. And normal ventricular sensing.
So a lot of these are normal pacemaker function, but they all look so different. But when you start looking at them this way, it's easy to see which ones are doing what they're supposed to do. Now we'll see some that aren't doing what they're supposed to do. Well, I guess this would be a comment then, what's going on here?
That's doing something.
Yes.
Sign.
But in terms of the way you approach it, it's
And there's none.
capture unknown in the atrium,
Yes.
normal sensing, capture unknown in the ventricle,
Normal.
normal sensing. So you have to recognize that there are shortcomings when the patient's own rhythm is good enough that you can't see any pacing activity. It doesn't mean that it's normal. It means the sensing is normal, but you can't say anything about capture. The same patient might have a pause and pass out if they can't capture.
atrial capture.
Or
Unknown atrial capture.
Unknown atrial capture.
Normal atrial
Sensing.
sensing.
Yes.
Normal ventricular capture.
And then
Unknown ventricular sensing.
Okay. You guys have the answers right there in front of you.
I've been covering it.
Oh,
That's
okay.
what I got.
It's right there, you know?
yes to atrial capture. Sensing no.
So the atrium capture works, sensing's unknown, and in the ventricle,
Capture unknown,
Sensing.
sensing. Appropriate. Normal.
Yes, atrial capture.
Atrial capture.
Unknown sensing.
Yes to
Normal
ventricular
ventricular capture.
capture,
Unknown ventricular sensing.
so I said we'd get back to this PVARP after a while. So the PVARP plays a role here. One second. So what's going on here is the PVARP means after any ventricular event, whether it's intrinsic or paced, we have a programmable period of time during which the atrium can't see anything. Actually, that's going to be for the next one. The issue on this one is the MTR, the maximum tracking rate. The maximum tracking rate is the fastest rate at which the pacemaker can pace. And in this case, it's set for 120. The patient's own atrial rate is a little higher than that. So the pacemaker tries to go that fast, keep up with the atrial rate. It can sense it, but it won't go any faster than 120. So here, it senses normally in the atrium, waits the programmed AV delay, and provides a pacing spike. The next one comes in, and that's actually a little bit faster than 120 beats per minute. So it can't keep up with that. But it knows it was there, and after extending the AV delay, it will then produce a pacing spike. But by extending it, it makes sure that the rate never goes above the maximum tracking rate. Well, it had to wait a little while here in order for that to happen. And you know what? It's getting behind. So now it's getting longer and longer. That's Winky Bach, right? This is pacemaker Winky Bach. And then finally, there's one that comes in, and it's actually in the complete refractory period. It's actually, see right on the T-wave there. So it's not even seen. And at that point, it can start over. So this is pacemaker Winky Bach, which happens when the sinus rate is only a little bit above the maximum tracking rate. So if someone's got a rate of 60 to 120 and they're going up to 130, you're likely to see this.
And is this something that you would want to be notified about, or
Generally
no,
not.
'cause it's still doing
It's
its
normal
job?
function.
Okay.
Normal function. The issue here is we're going to identify when things are working right and when they're not. The other thing that happens, and we'll talk about it in a short while, is pacemaker-mediated tachycardia. We talked about that last time, but I'll go back here. And that's because the pacemaker can act like a bypass track. It's another way of communicating between the atrium and the ventricle aside from the AV node. So what happens when the heart's going quickly like this is the ventricular signal can travel back up to the atrium. That's where the PVARP comes in. For 250 milliseconds after this, so one big box and half of a big box, the atrium is blind. It can't see that signal. And hopefully that's enough time for any signal that was going to travel backwards to do whatever damage it's going to do. Hey, I'm giving a talk. Can I help find it after I'm done? Okay. All right, no worries. Bye. Well, text me 5 times. Of course I'll never respond. All right. So, with a pacemaker-mediated tachycardia, a ventricular signal travels backwards to the atrium. It arrives there after the PVARP, so it can actually be sensed. The pacemaker says, I just saw something in the atrium, so I'm going to pace the ventricle. And it will automatically go as fast as it can. How fast is that? That is the maximum tracking rate. And then, because of the Winky Bach, the P wave will actually wind up falling within the PVARP. And at that point, that cycle is broken. And that's what you see here. It goes from pacing at the maximum tracking rate, because it's a pacemaker-mediated tachycardia, to pacing at a normal rate.
This might be a stupid question. Will the patient feel that, like a quick heart race?
They can.
Can they?
Absolutely, yep. So at this point, from this point here is Winky Bach because of the fast rate, or it could be a pacemaker-mediated tachycardia. And then once it breaks, once this falls into the PVARP, so that the system protects from this being sustained, then what would you say about the rest of the strip? Atrial capture, atrial sensing,
Yes.
ventricular capture,
Yes.
ventricular sensing.
Unknown.
So 2-to-1 block in the, oh, no, I'm sorry. Sorry. So this could be a pacemaker-mediated tachycardia. I should have remembered why I put this one in. But what happened here is the patient's rate was just a little bit above the upper tracking rate, so you got the Winky Bach. And then it got even higher still. And if you look here, and here, and
Yeah, I was
here,
gonna ask
and
about those
here,
or that.
these
Are
P
those
waves
P
are
waves?
all within the PVARP,
Okay,
so they can't be sensed. So now it's pacing every other beat.
gotcha.
So this is 2-to-1 AV
Oh,
block.
okay.
That's appropriate because of the PVARP, and it keeps the heart, keeps the pacemaker from tracking very high rates. So this is normal upper rate behavior. See, the 2-to-1 block is a safety feature built in. That's part of why the PVARP is there, so that as the rate gets high enough, it knows to try to pace every other beat instead of keeping up with the very high rates. Okay, in this case, it's much easier to see than on the last one. Same idea. Here, it's going, trying to keep up 1-to-1. The rate gets high enough
And then,
that the next P wave falls within the PVARP, which now you see has been extended out quite long, 350 instead of 250. So now it's every other beat. Because the PVARP is longer, you can get 2-to-1 block at a lower rate. Does that make sense?
yeah.
Okay. This one I just put up there just to let you know that it can get more complicated. So this is actually, this is something you would never need to do on your own. There's P waves here, here, at different points in the P waves. This is what's called 3-to-2 Winky Bach within the pacemaker. When it gets to this level, although it can certainly be diagnosed from here, often what we'll do is we'll put the programmer on the patient, and then we get the marker channel. And I'm just going to put a marker channel on this one, where the computer will actually show what the pacemaker thinks it sees and why it's doing what it's doing. So it'll show what it thinks is the patient's own sensed activity and what signals are coming from the device. That's more of the same. So, this is a pacemaker-mediated tachycardia, by far and away one of the two most common reasons for it to occur. And what it requires to start is a signal going from the bottom of the heart up at a time where the atrium is no longer refractory. So by far and away, the most common reason for it is a PVC. Because anything else, the atrium would have fired first and then the ventricle, whether it's paced or intrinsic, the atrium will be refractory. But a PVC is going to happen when the atrium is no longer refractory. And it will travel backwards through the AV node, be sensed, and start the pacemaker trying to track at the upper rate limit. So a PVC followed by the pacemaker running at the upper rate limit, 120, is a pacemaker-mediated tachycardia. PVC is the most common reason. The second most common reason is something that we do all the time. It's testing the device with a magnet. The magnet makes it asynchronous. So when you take the magnet off, if by chance the last thing that it was told to do was to provide a ventricular spike, then you'll trigger a pacemaker-mediated tachycardia. Fortunately, all you usually have to do is put the magnet back on, and it will stop. Initiation of a PMT following a PVC. All right, what's going on here? Atrial capture?
No.
You got a failure here. You have a nice long time here. That failed. Atrial sensing? Yeah.
There you go.
Ventricular capture?
Yes.
Ventricular sensing?
No.
And what else is going on here? What's different between this and all the rest of
The
it?
P waves.
So here you have atrial, an atrial event first, followed by the ventricle. And then what's this?
Your P wave is buried in your.
This is a PMT again. And I said the two most common reasons were PVC or using a magnet. In order for it to happen, what do you need? You need a ventricular event to occur when the atrium is no longer refractory. Here's a failure to capture in the atrium, so the atrium was never depolarized. It's not refractory. Normal pacer function would then provide a ventricular spike, and that starts the PMT, just like a PVC would.
Okay.
Because the atrium was never captured. Is this making sense?
Yes.
I told you the duals are a lot different than the single.
Yeah.
Alright. So the loss of atrial capture resulted in the initiation of the PMT. Okay. Atrial capture,
Yes.
atrial sensing,
Unknown.
ventricular capture,
Yes.
ventricular sensing.
Yes.
It sees the PVC
Yes.
and puts off. Yeah. So this is normal. And yeah, there is a retrograde P wave here, but it's in the P-warp, so it doesn't trigger the pacemaker mediated tachycardia. All right, so it's the same thing. Atrial capture, atrial sense, ventricular capture, ventricular sense. Okay. I'm not going to go through all of these, but there are a couple that I'll just describe them in words, and then I'm going to show a couple of little things. So the difference between the AV and the PV delay we talked about. Should I revisit that, or you guys got that? The intrinsic conduction delay is set much shorter, but the real delay is the same. All right. Rate responsive AV and PV delays. You'll often see it programmed like that little box that you saw in all the other ones. You know, like this. And we have a PV delay and an AV delay of 200 or 150. Rate adaptive AV delay allows the AV delay to shorten as the heart rate goes up. Because refractory periods change as heart rate goes up, and because it's more physiologic. When you're exercising, the mechanical coupling, the movement of blood from the atrium to the ventricle is very different. Also because afterload goes down with exercise, the heart empties better, it's a lower volume and can fill better. So it's more physiologic. The other thing it does is allows for the device to track to higher rates. This is, these 3 lines are for the programmed AV delay, and this is for the PR, the intrinsic PR. And they can just, as the heart rate goes up, we can make those go down. And these 3 lines here and these 3 lines here just have to do with the 3 different levels we can set it for. We can set it for what's called a low, medium, or high rate adaptation. Unless you're paying really careful attention, you're not going to notice that the PR intervals at one rate and the PR intervals at another rate are different. But if you did see that and it was all paced, that's what's going on. It's rate adapted, mostly seen in young patients. And the benefit is it mimics normal physiology. And the same thing can happen with the PVARP. We can change the PVARP with heart rates. And that will allow us to get to higher heart rates with less risk of a PMT. So I just highlighted in yellow the 2 points that are worthwhile. Is it's more physiologic, and it allows for higher maximal tracking rates. Because if we set the maximum tracking rate too high, it can cause problems. But if it's associated with exercise, it auto intrinsic conduction search. What this does is, if possible, in some patients, it's better if they have a narrow QRS, their own QRS, than a paced one. So even though we have a programmed AV delay, what we can do is tell the device periodically to extend that AV delay and see if there's a QRS there. And if it is, then keep it extended. And if there isn't, then it shorten it back up again. And it will do that periodically. And that can be set, in some cases it checks every 5 minutes for one cycle. Sometimes it can be set to every 8 hours or even every 24 hours. And what you may see are dropped beats because of that. And it looks like the pacemaker is failing to function for a single beat. And it's just this mode working.
For the PMT, can they ever come out of that on their own, or is that always something they have to do, like the magnet? Or...
Yes, usually if another PVC comes by. It can
okay.
come and this, well, that's the mechanics of how that thing works. Negative PV delay with history. So the long way of saying, sometimes we want every QRS to be paced. And this does the opposite of what we just looked at. What this does is it looks to see if any paced or intrinsic P waves are actually getting through to the ventricle. And if it is, then it shortens the PV delay to force a wide QRS. There's really only one reason for that these days, and that is hypertrophic obstructive cardiomyopathy. So if you remember in that case, the septum and the free wall of the ventricle are so thick that when they squeeze, they can actually come right up to each other and obstruct the ventricle below the level of the aortic valve. So now the heart can't empty. People pass out or worse. They are exquisitely sensitive to drops in preload, and often if they go to the OR, they'll do a septal myomectomy to reduce that mass. If they have a pacemaker, we can use this feature because when the QRS is wide, the free wall and the septum don't contract at the same time. One moves, and then by the time it's relaxing, the other one moves. So it tends to keep them from obstructing. That's, what the heart looks like cut in cross section. So the aortic valve here, if these two walls touch each other, this part of the ventricle can't empty. So what we always look at are the mid-cavitary gradients. The more it obstructs, it's like putting your thumb over the end of a garden hose, the pressure gradient will get much higher. So at breast, the gradient in the mid-ventricle was about 77 millimeters of mercury, and the cardiac output was about 5.3 liters per minute. With pacing, at 1 year, the gradient had fallen from 77 to 19 millimeters of mercury, much less obstruction, and the cardiac output didn't change at all. So this data is the reason why pacing is often used as a first step for IHSS or for hypertrophic obstructive cardiomyopathy. And at the end of 5 years, and this was tracked because if you pace all the time, sometimes you can induce a myopathy. Here I've talked about a pace myopathy, and that's why people sometimes get upgraded to a BIV, but in this population, you wouldn't want to do that, because what does a BIV do? It contracts both sides together.
So you're causing the same problem
Exactly
you're trying
right.
to fix.
Yeah. Section maybe of history is this. Rate hysteresis we talked about, just laying it out more specifically. It allows the intrinsic rate to drop below the pacing rate before pacing will occur. So if the lower rate limit is 60 per minute and hysteresis is 5, then the intrinsic rate would have to fall to 55, but then pacing would start at 60. What this means, though, is you can have intrinsic rates between the 55 and the 60 that look like the pacemaker's not doing its job, but it is. Rate hysteresis, you need the detection of an atrial event after the PVARP, and in the atrial alert period, just turn on rate hysteresis. That's a long way of saying it has to happen because of the patient's own rhythm. So an atrial event has to be sensed when the system's not refractory. That's the criteria it uses to say this is the patient's own rhythm. Once it sees that, hysteresis is turned on. Pacing in the atrium disables rate hysteresis, and the sensor, if it drives the rate up, it turns off hysteresis. We talked about the sensor a little bit last time. Base rate is 60, maximum track rate is 120. If the patient's own rate is going up and down, it's just tracking that. But it can use a sensor, either motion or respiratory rate, to say, well, the base rate shouldn't be 60 now, it should be 70 or 80 or 90 because I'm sensing activity. Once it changes from the base rate to some sort of activity or sensor-driven heart rate, there's no hysteresis. And it's just a diagram. The normal pacing interval is here because it was paced. Here it saw an intrinsic P wave, a normal P wave. So it adds that little extension on that creates hysteresis. And that will continue until it sees an event that is paced. So here's atrial pacing, that terminates hysteresis, and the RR interval gets short again. As long as the P waves are happening on their own, it can continue to go slower. There is a cycle count, and I bring this up just so that it doesn't, if you see hysteresis, I showed you all cases where it was on 1 beat. Sometimes if there's a lot of heart rate variability, we can extend that out and say it has to be 2 or 3 beats in a row below that trigger rate in order to happen. These are the last 2 things, and they're related. This is called the PVC mode or PVC safety. The idea is that PVCs are the most common cause of a pacemaker-mediated tachycardia. So the device has ways of trying to decide if it sees something that it actually thinks is a PVC. Earlier I said that sensing is sensing in the ventricle. But this is a way for it to make a distinction between whether it's a PVC or not. A PMT is initiated when there's loss of AV synchrony, and a PVC is the most common cause. Atrial loss of capture, and we saw an example of that before, or undersensing can be another one, or the removal of a magnet. And the pacemaker acts like a re-entrant pathway. That's the second we talked about. And I showed you lots of examples of that. So the PVC option is either turned off or it adds extra time after a PVC to extend the PVAR so that the atrial system becomes refractory for a much longer period of time after a PVC. Off is, just off. So PVC is defined as an R wave seen by the device that was not preceded by either a paced or a sensed atrial event. So if it did not see a P wave, did not provide an atrial pacing spike, and it sees an R wave, it's going to call that a PVC. And if it sees that, then it's going to add some extra time onto the PVAR. So any signals that are traveling retrograde through the AV node to the atrium won't be seen. So normally the PVAR is comprised of 2 parts. It's comprised of an absolute refractory period and sort of a less absolute refractory period during which it can still keep track of stuff that's happening, but it wouldn't necessarily act on it, wouldn't necessarily pace from it. So those are the 2 parts that make up a normal PVAR. If it sees a PVC, so here's a normal atrial paced event, ventricular paced event, then it sees an R wave with no preceding P wave and no preceding atrial spike. So a ventricular event with no preceding P wave or atrial pacing is, it considers a PVC. It takes the 2 parts of the PVAR and then it adds extra time here. And that way, the signal that traveled retrograde can't start the PVC. It occurs during this time of silence. And then the regular rhythm continues again. So if you see a PVC in a very long gap before the next pace beat, that's the system preventing the initiation of a PMT by extending the refractory period. It's all in there. Oh, okay.
I have hungry. I go, oh,
And
so much water I can put in.
last thing here is PMT. You would ask, can it stop? Can a PMT stop? I forgot to ask that. Okay. So, although there are some variations on the theme, basically, if 10 consecutive beats are found at the upper tracking limit, the pacemaker thinks this is probably a PMT. So it confirms that, and there are ways of setting that detection rate. I don't know why I put the details in there. And if it sees that, what it will do is add a gap and delay the next pace beat for a short period of time, 480 milliseconds, about a half a second, it's not really short, and then go away. And if the tachycardia persists, then it's probably an atrial tach or some sort of intrinsic tachycardia, but otherwise it'll break the PMT. So most PMTs shouldn't last more than 10 minutes if this feature is turned on. And then it'll try again after 256 cycles. So this is an example of, these are the marker channels that you get out of the computer. It tells you P and V and A, well, P and A, R and V are the way it tells you whether it's seeing the patient's own stuff or what the pacemaker is doing. So here's a PMT. It sees the ventricular event, travels back to the atrium, seen by the pacemaker, which thinks that that's a legitimate P wave, paces the ventricle, which then goes back. And at the end, it does that for 10 cycles. The pacemaker will add an extra refractory period, after which there is no P wave, because these P waves were only coming from the fact that the ventricle was paced when the atrium was no longer refractory. So there's no intrinsic atrial activity. These P waves here were coming from the ventricle up. By extending this gap, the same thing happened. The P wave went up, but it was during a time where the pacemaker was refractory. And after that, there are no P waves anymore. And the device is providing atrial pacing and then ventricular pacing. Auto detection, I'm not going to talk about it. It's very complicated. And this is what I was talking about before. It would go out 10 beats, it extends the delay, and then it breaks the PMT. Rest rate is something else that you'll see on the floor that can be a little bit confusing. I'm not going to go through the whole thing because of time and food, but there was a time where pacemakers were set up to say, well, during sleep, everyone's heart rate goes down lower. Maybe it's more physiologic to do that. And then they'd set, a timer in there from 11 o'clock at night till 6 in the morning is sleepy time. And it turned out that was bad. People would get up during the night. People wouldn't go to sleep on an exact schedule, and it wasn't very physiologic. So instead, what these devices do is it uses that same sensor that we use for increasing the heart rate with activity to also sense periods of rest. And it can use those rest cycles to try to predict what someone's sleep habits are. But then if you get up during the night, your Lasix kicks in, or you have to go pee, or you heard a noise, it can recognize from the activity sensor that the sleep pattern is broken, and it will interrupt that sleep cycle. If this is turned on, it's the reason why somebody who has a base rate of 60 who's sleeping on the floor may suddenly be paced at 45, and you're wondering, is something wrong with the system? And it's if the sleep rate is on. It's not used as much anymore. Nobody's ever really been able to demonstrate that there's a big physiologic advantage, but sometimes you'll see it. So it collects data over, you'll never see this on devices that are newly implanted, because it takes about 7 days to learn what the sleep cycles are and establish that pattern. And then AMS is the one thing that you actually will see a fair amount of. AMS means automatic mode switch, and what it does is it has the ability to detect when the atrial rate goes real high, that it probably shouldn't try to keep up with that anymore. The most common reasons are SVT, AFib, and AFlutter. So this is an example. This is from the programmer. It shows that it's sensing a P wave. It's providing a ventricular pacing spike. So it says P for P, V for ventricular pacing, not R. So this is an atrial sense ventricular pace rhythm that continues for a little while. And then right around here, atrial flutter develops. And it starts to see all those P signals here. And then AMS turns on at this point, and it converts from being a dual chamber pacemaker to being VVI pacemaker. But it's not truly a VVI pacemaker because it's still sensing in the atrium. And if the atrial rate ever falls back below what's called the PMT detection rate, then it'll go back to a normal dual chamber pacemaker. So if someone goes into fib or flutter, you may see it try to keep up with it for a little while, 10, 20 beats, and then suddenly drop to 60 or 70. And the PMT rate is often different than the base pacing rate. So if someone's programmed to go from 60 to 120, and then they're suddenly pacing at 70 or 75, it's because it probably saw atrial fib or atrial flutter, and instead of falling all the way to the lowest possible rate, we can set it to a higher rate, something that may be more physiologic, because there's a certain amount of stress and so forth that goes along with developing an atrial arrhythmia. So the PMT programming that you guys would need to know on the floor involves two things. What's the PMT detection rate? How high does the atrial rate have to go before it's going to do this? And then what's the PMT pacing rate? It's going to fall to some lower level, but it may not be all the way down to 50 or 60 that was the base rate. That's it.
Thank you.
Thank you. Thank you.
A lot of stuff. You guys did really good on the strips there.